Rhinology from Scott Brown Book of ENT, Chapter 87, Anatomy of the Nose and Paranasal Sinuses. Introduction. This chapter outlines the embryological development of the nose and paranasal sinuses, neurovascular and anatomical structures of the external nose, nasal cavity, and nasal septum. A surgically relevant approach to the paranasal sinus anatomy is discussed with a focus on fixed anatomical landmarks and the concepts of the horizontal and vertical components of the paranasal surgical box. The anatomical descriptions and surgical relevant anatomical concepts are based on standard text, peer-reviewed journals referred in the bibliography, and the author's personal experience. Development of the nose and paranasal sinus. Traditionally, teaching of paranasal sinus anatomy focused on embryological development of the pathways of pneumatization with limited clinical application. These descriptions are included for completeness, but the emphasis in this chapter is on the surgically relevant anatomy. External nose and nasal cavity. The nose develops from a number of mesenchymal processes around the primitive mouth during the 4th week of gestation. Collections of the neural crest cells undergo proliferation and form the nasal placods. Sinking of the nasal placods leads to formation of the nasal pits, which further deepen to form the nasal sac. Adjacent mesoderm cells proliferate to give rise to the medial and lateral nasal prominences of the frontonasal process, which surround the nasal pit and sac and eventually become the nares. The maxillary process grows anteriorly and medially to fuse with the medial nasal prominences and frontonasal process to close off the nasal pits and form separate nasal cavities. The primitive nasal cavity and mouth are initially separated by the bucco-nasal membrane. This membrane gradually thins as the nasal sacs extend posteriorly and eventually breaks down to form the choana. Failure of this membrane to break down results in choanal atresia. The frontal and maxillary processes fuse to give origin to the lateral 2/3 of the upper lip, superior alveolar ridges, and palatal shelves. The medial nasal prominences fuse with the maxillary process to form the philtrum and medial crust of the lower lateral cartilages. The lateral nasal prominences form the nasal bones, upper lateral cartilage, and lateral crust of the lower lateral cartilages. This figure 87.1, embryological development of the primitive nose and the palate during fusion of the maxillary process to the lateral and medial nasal processes. Lateral nasal fold, medial nasal fold, maxillary process, Rathke's pouch, primitive posterior nares, eye, frontonasal process, forehead. Box 87.1, failure of the bucco-nasal membrane to break down during embryological development leads to choanal atresia. Palate and the nasal septum. The septum develops from the posterior midline growth of the frontonasal process in the root of the oral cavity and extends posteriorly to the opening of Rathke's pouch. The primitive or primary palate begins to form anteriorly with fusion of the maxillary and frontonasal processes. As the nasal cavities enlarge, the palatal processes derived from lateral maxillary mesoderm grow medially towards each other and the nasal septum. Initially, the palatal processes are vertically oriented and lateral to the tongue. Further growth of the jaw and oral cavity enables the palatal processes to migrate medially towards the midline and fuse. The fusion begins along the posterior margins of the primitive palate and progresses from anterior to posterior to form the secondary palate. Partial notching of the posterior hard palate represents an incomplete fusion of the secondary palate and may indicate a submucous cleft. A midline dehiscence in the fusion of the primary and secondary palate forms the incisive foramen. Maxillary sinus. The maxillary sinus is the first sinus to appear between the 7th and 10th week of gestation. The maxillary sinus appears as a shallow groove expanding from the primitive ethmoidal infundibulum into the mass of the maxilla. Expansion and absorption results in a small sinus cavity present at birth. Rapid growth of this cavity occurs during childhood until age of 7, followed by gradual enlargement, reaching its final size by age 17 to 18 years. Growth may continue beyond this period with extensive pneumatization involving the entire hard palate. Any disruption or abnormality in the development of the maxillary sinus may result in maxillary sinus aplasia or hypoplasia. Maxillary sinus hypoplasia is present in up to 10% of CT scans. Radiographic diagnostic criteria for maxillary hypoplasia include enlargement of vertical orbit, 2. Lateral process of the infraorbital neurovascular canal, 3. Elevated canine fossa, 4. Enlargement of the superior orbital fissure, and 5. Enlargement of the pterygopalatine fissure. This is the diagram, figure 87.2, section through the developing palate of a 20 millimeter human infant fetus. The palatal shelves are positioned vertically due to occupation of this space by the tongue. Septal cartilage, developing inferior turbinate, warmer row nasal cartilage, tongue, palatal process of maxilla, tooth bud, Meckel's cartilage. Figure 87.3, section through the developing palate of a 48 mm human fetus with further growth of oral cavity to accommodate the tongue. The palatal shelves are being migrated medially into a horizontal position and begin to fuse into a anterior to posterior direction. Septal cartilage, developing turbinate, vomeronasal organ, fused palatal and septal processes, tongue, Meckel's cartilage. Figure 87.4, coronal CT of extensive maxillary sinus pneumatization into the hard palate, arrows with evidence of maxillary sinus dysfunction, left greater than right. Ethmoid sinus. During the 9th and 10th week of gestation, a series of folds called ethmoturbinals that are separated from each other by corresponding grooves appear in the lateral wall of the nasal capsule. Fusion of these folds leads to the development of crests, each with an ascending and descending portion. All permanent ethmoidal structures are present at birth and develop from these crests and the furrows between them. As a result, acute sinusitis in children often involves the ethmoid cavity, which can extend laterally through the lamina papyracea, causing orbital complications. Box 87.2, the ethmoid structures are present at birth and acute sinusitis involving this cavity can extend laterally and result in orbital complications. Understanding the basic embryology of the 4 or 5 ethmoidoturbinals defines a series of lamina that may be removed in order to pass from anterior of the sinonasal cavity to the sphenoid sinus. In order from anterior to posterior, these lamella include first agonasi, ascending portion, and uncinate process, descending portion. Second, bulla ethmoidalis. Third, basal lamina of the middle turbinate. Fourth, superior turbinate, and fifth, supreme turbinate if present. Sphenoid sinus. Figure 87.5, coronal CT demonstrating maxillary sinus hypoplasia on the right side and maxillary sinus atelectasis on the left side. Sphenoid sinus. The sphenoid sinus begins to develop in the 12th week of gestation as an imagination from the sphenoethmoidal rhesus. A small sphenoid sinus is present at birth with progressive enlargement starting at age 3 during pneumatization of the sphenoid bone. 3 pneumatization patterns have been described with reference to Sella turcica. These pneumatization patterns are important for surgical planning of transsphenoidal approach to pituitary tumors. These include cellular 90%, pre-cellular 9%, and conchal 1% type pneumatization patterns. The cellular type is most common and describes sphenoid pneumatization posterior to the Sella turcica. The precellular type describes sphenoid pneumatization up to the sphenoid anterior cellular, and the conchal type describes a shallow bowel with minimal sphenoid pneumatization. Up to the anterior cellular, and conchal type describes a shallow bowel with minimal sphenoid pneumatization and trabecular bone between the sinus and cellar. The sphenoid sinus can also pneumatize laterally into the pterygoid root, resulting in the presence of a lateral sphenoid rhesus. This pneumatization pattern results in exposure of the neurovascular structures surrounding the sphenoid. Figure 87.7, coronal CT of sphenoid sinus, lateral sphenoid rhesus, asterisk, maxillary division of trigeminal nerve, arrow, median nerve, arrowhead. Sphenoid sinus pneumatization patterns. Middle sagittal CT indicating A. cellular, B. precellular, and C. conchal types of sphenoid sinus pneumatization patterns. The lateral rhesus pneumatization pathway occurs between the second trigeminal division and median nerve. Box 87.3. The 3 different sphenoid sinus pneumatization patterns are described with reference to the Sella turcica, and these include cellular 90%, pre-cellular 9%, and conchal 1% type. These pneumatization patterns are important for surgical planning of transsphenoid approaches to pituitary tumors. Frontal sinus. The frontal sinus is the most variable sinus in terms of size and shape. Pneumatization of the frontal bone begins during the 16th week of gestation, originating from the anterior ethmoid complex. At birth, the frontal sinus appears only as a small blind pocket that is difficult to distinguish from the anterior ethmoid air cells on imaging. With gradual pneumatization, the frontal sinuses are seen in most radiological studies by the age of 8 years. Significant frontal pneumatization does not occur until early adolescence and continues until 18 years of age. Although still developing, the relative proportions of the frontal sinus have reached adult ratios by age 10 to 12 years and just prior to the second growth spurt. Thank you.